you ought to be starting to think about it. If there are 1.2 million people out there with hypercortisolism, which looks like the number we're coming up with, that's a lot of people who are poorly controlled. And so, obviously, you'd like to do something. Well, in order to do something, you need to establish the diagnosis. You can do that with the dexamethasone suppression test. So you have an abnormal dexamethasone suppression test. Next step is you need to ask yourself, assuming you ruled out pituitary Cushing's, the ACTH is low. So now you do the adrenal MRI.
Can you tell us a little bit about the changes that came over this weekend and what was announced?
Wow. Well, there's been a lot of exciting things here at Scientific Sessions, but one of the things we announced is the formation of the Obesity Association, which is a division of the American Diabetes Association, and it allows us to really focus deeper on an area that we've actually been involved in for years. We funded the early research around GLP-1s and, the new sort of treatments that are available. The standards of care has had a section around weight management for a number of years. We've done a lot in this field, and because of the importance of it and the opportunity that we see all around at Scientific Sessions, we want to be able to focus more deeply on this. It'll also be a platform for us to work from an advocacy perspective, because although we have effective therapies, not everybody's getting them.
Right. I mean, and some of that's because of insurance coverage. Some of that's because of obesity bias. Some of that, I mean, I could just see this, and we can even reach then into pre-diabetes. I love this. Right.
Well, and yeah, I absolutely all those things. And on top of that, we're also looking to, in the way that we create the standards of care for diabetes, to do something similar for obesity.
I love it.
That would look not only at obesity and diabetes, which we currently look at, but really more broadly, and sleep apnea and the various other issues that relate to people living with obesity.
So if I heard you right, there could be a separate standards of care in the future for obesity and weight management.
That is a possibility.
That would be, oh my God, is that right? It's really amazing. Would it be a separate professional practice committee? And
it would be a separate group of individuals, yeah, because we would have to, we would ensure that these were the greatest experts in the world of obesity. But the same way that the professional practice committee identifies those individuals.
The answer is I don't know. Certainly weight loss is driving some of the findings, no question about that, in my view. But when you look at the change in body weight versus the change in sleep apnea in general, and meta-analyses and whatnot, there's some scatter there. And so some people lose a lot of weight, their sleep apnea resolves, some people not so much. And so I believe there probably are other mechanisms in play. The FLOW study was recently published in the journal with semaglutide. And they had, 4 kilograms of weight loss. It wasn't much, but they saw cardiovascular mortality and overall mortality improvement. So I don't think 10 pounds of weight loss is saving lives like that. I suspect there's other factors in play, as you alluded to. Yeah, the results are consistent with clinical experience, where some people get some nausea and some people get some GI side effects. Many more people dropped out of placebo than drug, suggesting the drug is pretty well tolerated. And the number of patients stopping medication as a result of side effects, at least in the trial, were quite few. And when you talk to active clinicians who are prescribing these products, the medications are in short supply, not because patients stop taking them after 3 weeks. It's because everybody's put these medications in high demand. So I think that some of the side effect concerns are probably overblown. Yeah, I think our metrics of sleep apnea severity are not very good. The apnea-hypopnea index is typically what we use, but it's not a very good yardstick for disease complications. Some loose predictor of symptoms and all that. So I think the secondary outcomes are crucial. We looked at the hypoxic burden, which is the area under the hypoxic curve, which appears to be a strong predictor of cardiovascular risk, and that did improve markedly with tirzepatide versus placebo in both arms of the study. We also looked at C-reactive protein, which is a strong cardiovascular risk marker. That also improved markedly. Systolic blood pressure with whopping improvements that are 8 or 9 millimeters of mercury in both arms of the study compared to placebo. And then patient-reported outcomes also improved. So sometimes we make the numbers look better, but the patient doesn't feel better. In this case, patient-reported outcomes improved concomitantly, and that's all quite reassuring that we're doing something good.
We are going to start off in the insulin pump space and automated insulin delivery, where there was so much information, very, very exciting. But one of the things that we were particularly eager to see was what's called the Secure T2D study, which was with the Omnipod 5 in people with type 2 diabetes. And I think you're going to see this is a growing area where we're looking to use the same technologies, which have truly become the standard of care in type 1 diabetes, for people with type 2 diabetes that require insulin, specifically usually mealtime insulin.
So in DKA, the diabetes ketoacidosis, your blood sugars go up first, then you get ketosis, then it triggers the GI symptoms such as the nausea and vomiting. But in hyperglycemic ketosis related to cannabis hyperemesis syndrome, which is a part of the cyclic vomiting syndrome, the first thing is triggered by the GI problems. And then you are not able to eat, drink, and you have nausea and vomiting, then that increases your ketosis and your blood sugar. And then the presentations looks like similar.